Hello everyone, welcome to today's video where we'll be talking about mastering the clinical handover process, and I'll be providing a step-by-step guide for health professionals to enable them ensure an efficient clinical handover. This is a much requested video by a lot of my junior colleagues and a lot of you, my viewers, especially those in the health professional field. And I've been asked on multiple times what is a good clinical handover, and also just being on this side of where I work at the moment, in the role that I work at, in the various roles that I work at, is sometimes I get a handover and I'm like, so what did you really want to say? So I feel if you develop your own structure of doing clinical handover, it's going to be very, very good for you, especially if you're working in the health space, either as a nurse, either a doctor or a junior doctor. And it will be a lot easier, especially for junior doctors that are wanting to speak to their seniors and stuff like that. And also seniors that are wanting to talk to one another and stuff like that. So this is a very important video, and I really want you to listen in, and let's share some thoughts, and I will share with you this structure that I have seen that has been very helpful to me. So let's learn the structure. So why is clinical handover an important topic? Clinical handover is a crucial process because what it does, it ensures that patient safety is adhered to, but also provides continuity of care. So you're able, with your clinical handover, you're able to transfer care from yourself to another treating team. So very important to appropriately do your clinical handover. So I like to use the ISBAR framework, which is a common framework that's used across, in the Australian healthcare system. And essentially, I'll go through it. So ISBAR essentially is introduction. So when you meet or when you're doing your clinical handover, identify yourself and your role. Like, let's say, for example, my name is Dr. Anna. I am an SMP, or I'm a senior registrar, or I am a general practitioner, and confirm who you're talking about. So my name is Anna. I am a general practitioner, and I would like to talk to you about Mr. So-and-so. And then after that, you need to introduce the situation that you're talking about. So briefly provide an overview of the patient's condition and the current clinical status. So-and-so is a 70-year-old gentleman that is in with heart failure, and he is clinically unwell. And then you provide the background history. In the background history, you're essentially talking about the relevant medical history. So this gentleman has a background history of having diabetes. They do have a background history of having chronic kidney disease. And they are currently on the following treatment. They're currently on an insulin dex infusion. They're currently on pain management. And they, just introduce that by giving the relevant medical history, and then obviously provide the current treatments and the current medication that the patient is on. And then the third process is you need to talk about the assessment, your own assessment. Sometimes some criteria is usually put in the O in the ISBAR or ISBAR, and O would be, your objective findings of the patient. The objective findings of the patient, like, heart rate, blood pressure, and stuff like that. But after that, after ISBAR would be your assessment. So provide the current assessment, provide the diagnosis of the patient, also provide your assessment. Like if you've seen a patient and they're clinically deteriorating, this is the time that you'll say, my concern about this patient is their blood pressure is downtrending, and I am worried about them because of 1, 2, and 3. Okay, and then provide recommendation, your own recommendation. I always say, when you're talking to your seniors, you're a doctor in your own form, you're a nurse in your own form, do your own assessment, do your own recommendation. I think this patient needs pain management. I think this patient, if you're a nurse and you're talking to a doctor, I say, I think this patient needs assessment because the blood pressure has been downtrending. And if you're a junior doctor to speaking to a senior consultant, say, look, I need you to come and reassess this patient patient and let's come up with a plan together. So at the recommendation stage, you need to be providing your plan for ongoing care. So this patient will be going for a CT scan. They've done a chest x-ray, but what is remaining is a CT scan. Kindly follow it up. So plan of ongoing care is important for you to reinforce at that point in time, and then also provide the tasks that are already completed and those that are yet to be completed. So the people that you're handing over care to are aware that this is what has been done, this is what is pending, and it will allow them to follow up what is important and what is remaining. So in the clinical handover process, generally, I find, and this is something that I've observed, and a lot of times when I'm providing feedback to those that I work with, and I say this because it is an area that I've had to develop over time, I find always, like Australians are so structured, and that's the difference between an Australian graduate and an IMG. They're so structured. They're taught these things at school, but then you as an IMG coming to Australia, you have no clue. I mean, you have your own way of handing over back in your country and stuff like that, but you realize that as soon as you come here, you need to develop your own structure so that when you're talking to people, you know how to do it. So my advice would be, when you're preparing your clinical handover, it's almost end of shift and you need to hand over a patient, first and foremost, prepare. Okay, so review the patient's charts and notes, gather relevant information. So then after that, you can put that information into the relevant aspects that I've talked about. And again, I will say the next thing that you probably need to do is, again, need to introduce yourself, need to introduce the patient, say who you are, the process itself is saying who you are, talking who the patient is and stuff like that. And then remember to provide context. I am calling you from the maternity unit. I am calling you from ICU. I am calling you from, I'm calling you because we've had a met call. Because context changes everything. So if you're reviewing a patient at a Cord Blue or at a met call situation, that's completely different from just a general review. If you're a nurse and you've noticed that the patient has, their vital signs are off, it's important to say, I was doing the routine vital signs and I noticed that this patient is tachycardic and blood tooth. That is completely different compared to a patient who is short of breath, they're tachycardic, they've called out for the nurse has reviewed. Or different to a clinical context where the patient has been found on the floor with syncope and now they're tachycardic. So context is very, very important, and it's important to look at that and consider it in your clinical handover. And that, of course, goes without saying the other medical issues that the patient has. The part of the process of preparing for your clinical handover, remember to share the key important information, talk about the patient's blood test, talk about the patient vital signs, talk about the patient's history, talk about, the patient's allergies, sensitivities. If they have a blood culture and the sensitivities have come back, remember to talk about that. So this patient is resistant to this sort of antibiotic. It's very important because that will advise the person on the other side of the phone to give you sort of a plan to say, look, start this sort of antibiotic based on the sensitivities and the allergies of the patient. And then very, very important, if you are doing your clinical handover, to think about, you have to talk about the plans and concerns. So sometimes I find when I was starting my career here in Australia, I would sometimes have to call a boss like once or twice. And I think that doesn't rub off well because obviously, I always share my story. You guys know I started in coronary care unit. I'd never worked in CCU before. And sometimes, the nurses ask you, find out this information from specialist so-and-so. And by that time, I'll be honest, I did not have a proper structure. So I would just call. And then later on, I realized, oh my God, I didn't get a plan. So if this doesn't work, what should we do next? I didn't get a plan. But with time, over time, I've developed structure, and then as part of the phone call or as part of clinical handover or as part of what I do is in my plan, I need I always discuss what's the current plan, what's the ongoing plan, what are the potential issues that this patient is likely to come to have. Say, for example, blood pressure is low, we are going to give fluids, but what happens if there is no response to your intervention? What's our next step that we are going to consider? Are we going to try albumin? Are we going to try this? Are we going to try this? And patient in pain, you've tried this, you've assessed, there's no clinical concern of, like, let's say, a surgical abdomen and stuff like that. So we are going to try tapentadol. If that doesn't work, then we are going to do 1, 2, 3. So it's very important when you're doing your handover to think about these things, because as soon as you put down the phone, you do an intervention, and then 1 hour later, you're calling the boss again, and you're calling again. So that can be frustrating to the other person on the phone. And then always try, whichever side you're on, to clarify the tasks, clarify the things that are pending, clarify who's going to do what. And I find this very important if you're doing something like, let's say you're running a cord, or you're seeing a sick patient, you're on after hours, you're on a night shift, and you've seen a patient together with an RMO or stuff like that, the people that you round with. At the end of it, just remember who's going to do what. So am I the one going to chase the bloods, or are you the one going to chase the bloods? And in a met situation, who's going to call the consultant, who's going to talk to the family, and who's going to, discuss with ICU? Just generally divide the tasks so that you know who's doing what, and to ensure everybody is on the same board. And the other thing that I find is have sort of like a time frame. Look, so if you've reviewed a patient and you want to see a clinical response, tell yourself that I'll review this patient again, let's say in an hour or in 2 hours time, or when you're handing over, like you have a patient that has high potassium, and you've given some intervention, so you hand over and say, look, I need the bloods repeated in 3 to 4 hours so that we see if there's been a response or not. So those small little details are quite important. And always make sure and close the loop. Make sure that the other person is on board. I was watching the other day a very funny clip on, what is it called? I think on TikTok or something. And this doctor was talking about the fact that, they got a clinical handover on the phone, and they thought the patient was coming in for a cardiac arrest. And the way if there's a cardiac arrest, the way the whole unit is up and down, people are dividing roles. You're going to do this, you're going to do this. Defibs are put in place, the vent, everything is organized. But then what the patient was having was, patient arrives and they're seated up, they're looking, and the doctors are like, this is definitely not a cardiac arrest. This patient's not dead. So very important, because patient was under arrest, with the police under arrest. So very important to always close the loop and say, oh, did you actually mean I need to give insulin this amount? And then make sure that the other person is on the same page with you. Yes, 10 units of Novorapid. Yes, 1 gram of antibiotics, ceftriaxone antibiotics and stuff like that. So close that loop, because errors can happen in a loop, especially in stressful situations like coded patients and stuff like that. Always close the loop and say, yes, adrenaline's been given. Yes, I've completed this task. VBG is back. Or, close that loop. Don't leave things hanging. And then importantly, so in every clinical handover, you have to document. If it's not documented, it's not done. You have to document, your handover. You have to document, put in the date, time, and obviously write in there your signature, and just to, for accountability purposes as well. So in general, this is the structure that I like to use, and I think it can be helpful to you, but at the end of the day, you still need to develop your own structure, because whatever you develop, you're going to own it, and you will keep doing it. And the more you do it, the more you will master it, and it's going to be extremely easy. I find it's, so much easy, even as you scroll through the patient's notes, you go like, I have so-and-so, they are this number of years, they have a background history of so-and-so, they're on these current medications. I'm worried about them because I've reviewed them and they have 1, 2, 3, 4. This is the assessment, this is the blood pressure, this is the heart rate, this is my assessment that this patient is clinically unwell, showing some signs of infection. Apart from the IV fluids that I've given, I'm thinking of starting some IV antibiotics, and I'll review the patient in 2 hours. And yeah, do you have anything additional to add? Is there anything additional I need to do? That way people know that, you're thinking, you're a doctor. And obviously, yeah. So what are the tips that I would sort of, verbal handover tips that I would say you need to work on? Ensure that you have a clear and concise language. Avoid jargon. Jargon in clinical handover is not helpful. Avoid abbreviation, they're not helpful. Some people will say sitting out of bed. Some will mean something completely different. PTA may say, patient to come back or to return. It may mean completely different to another person. So avoid jargon, avoid abbreviation, be clear, be concise. To the point. Don't say patient, last had dinner at 6 a.m. If it's not a surgical patient, like if you're not thinking about surgery, nobody will care about if they had, bread at 6 a.m., but they will care if they've had bread at 6 a.m. and you're thinking about surgery at 10 a.m. So context is key. And then obviously the other thing is remember your framework, ISBAR or ISBAR or whatever it is that you're using, and stick on it. Importantly, to just put in the important things. Long are the days when we would do clinical handover and say history of presenting complaint. Your notes will have all that, history of presenting complaints, your background history, blah, blah, blah. But when you're doing the clinical handover, you need to, go through that information, pick up the key features, put them in a summary, and speak it back to whoever you're speaking back to. And then always allow some time for questions and clarification. Make sure, people are on the same the same page with yourself. People are understanding of what you're talking about. And obviously, don't be in time rushed. Don't be in a rush to leave and forget to give out handover to the important people and to those patients that are unwell, just to make sure, nothing important is missed. Important blood tests like troponin and, things that need timely interventions are not missed. They are done. Don't rush it. Make sure that you provide a proper handover and make it easier for your colleagues and the patient safety. And always remember to use open-ended questions if you are not sure, to ensure that the other person understands what you're talking about. Okay? Lastly, what are some of the things I've noticed that can affect a good clinical handover? Okay, and this is my sort of experience that I must say there are a few things that can affect handover. I've already talked about one of them, time. Sometimes we are all rushed. Look, you're picking your son from daycare, or you're rushing for a meeting after work, or you're rushing for an appointment after work, and you rush your clinical handover. And sometimes you can miss important things. So remember to factor in the important time for handover. No wonder a lot of jobs will have a time frame put into the roster for clinical handover. Like you'll notice a lot of times, shifts will have 30 minutes put aside for handover so that, we do a proper job at handing over patients and are not rushing through. The other thing that I must say is that can be a barrier to good verbal clinical handover is when you have so much to say, so you're overloaded with information. Information overload can be a nightmare. So sometimes how I've gone around this thing is if I have a patient that's completely complex, I put their medical story or my concerns as issues. So I will say I have a couple of issues about this patient. One of them is blood pressure is not great. Another one is their sugars are not well controlled. Third one is, their urine output has gone down. And fourth one is, there are social issues with this patient. The family is like this, or we are struggling with 1, 2, 3. So sometimes when you have information overload, summarize it, find a way, and that's why I always say you have to still develop your own structure. Find a way of summarizing things so that it makes sense to the other person. And then obviously the other thing that I've noticed that can be a barrier to good clinical handover is when you don't do things in structure, when you just throw things around, when you don't have a standard way of doing things. I find you will be all over the place. You will talk about this, and then you jump, talk about this, and to be honest, I think it's annoying if you're on the other side of the phone, or you're the one taking handover, because sometimes you have to stop somebody and say, so, yeah, and sometimes as well, for nursing handover, I need you to review this patient because of this, but then there's no standard, there's no structure. I don't know what the patient has. I don't know what you've done so far. I don't know. So you end up obviously taking a lot more time, because you have to go through the records again. You have to get more clinical information from the treating nurse and stuff like that. So if you have a good standardized way of doing your handover, it is very, it allows you to be quite efficient and good at what you do. So in summary, and this is something I tell everybody I work with, this is something that I always feed back to my juniors: you have to develop structure, regardless. You have to develop a structured way of providing all the important information, let's say within a minute, or even less than that, so that the other person understands the urgency of the case, the urgency of intervention that's required, so that they can make informed decision based on what you're saying. That will allow efficiency at work, that will allow and foster teamwork, and that will allow patient safety. So if you have anything additional to add or a comment, please comment on there. But importantly, share this video. Share this video in your circles, and to junior doctors and other professionals. Let's endeavor to do a good clinical handover to ensure patient safety. Thank you for watching.